a couple years ago, when many of you in the room came together to start the Institute, one of the things that we noticed was there wasn't a mechanism for honoring those who have made our life easier, those who have helped push the field forward in ways that we couldn't imagine, but that have caused us to be able to do things that in a much more expeditious way, and in a way that allowed us to be effective in translating science into a better practice. And so we started an award, 3 awards to be precise, around important areas for that have really helped the field of individualized therapy. And today we're going to be honoring the 2009 IPIT Award for patient service. This award honors a person. Each year we give this award out. This is the 3rd year we have done so. And this honors a person who has made significant contributions to empowering patients and who champions patient focus in the advancement of rational drug therapy. And so the focus of this particular award is around trying to make it so that patients are empowered to make better decisions, which is certainly a very timely thing because patients do have a lot more influence on how things are going forward. This year's awardee is Ryan Phelan, and she's the founder and chief executive officer of DNA Direct. It's a San Francisco-based company that delivers both guidance and decision support for genomic medicine to patients, to providers, and to payers. So the 3 key areas that are out there. And it's not only around the area of drug therapy, but around disease genetics as well. She has a really amazing focus around consumer health and has been an advocate in this area for the past 25 years. And so she was 6 years old when she started in this area, and was one of the first, or was the first, to start a medical library for consumers. It was back in 1978, and was a founding director of Plaintree, which is a nonprofit that is focused on consumer health and developing new models for humanizing hospitals and trying to develop better health information for the public. And so, while many of us are trying to humanize rats and mice, she's been trying to humanize hospitals and trying to make that better for patients. And then in 1995, she founded Direct Medical Knowledge, which was a very extensive consumer health website. This was purchased or acquired, I guess is the polite way of saying it, in 1999 by a little entity called WebMD, and really has been the backbone of the WebMD consumer health site. And many of you are familiar with that when you quickly try to look up what your aunt has and try to sound somewhat knowledgeable. And then in 2005, DNA Direct was launched, which includes resources for helping patients with genetics associated with drug therapy. So her vision for empowering patients has really been at the front of this, and trying to design tools that will make it so they can make wise decisions. So Ryan, if you can come forward. We have a fancy little knick-knack here, which now has my fingerprints on it, so we'll try to get it dusted off a little bit more. But I'd like to present to you the 2009 IPIT Award for Patient Service. So thank you very much for that. You can smile there.
Thank you, Howard.
Thank you.
It's really good.
And we'll be happy to, if you don't want your carry-on to now double in weight, we'd be happy to FedEx that out to you, or you can take it with you, whichever you
definitely.
prefer. So.
I'll keep it up here, though,
okay,
because it's exciting to have an award like that. Just get all my system together here. Thank you. That's really an honor, and it's an honor to be here with all of you today. I realize that I've been doing a math problem in my head incorrectly. I've been saying I've been at this for 25 years, and I guess the truth is it's about 30 now, if I compute back from 1978.
We won't tell anyone.
I'm curious, before we get started here today, how many of you in this room are actually clinicians? Can I see a show of hands? Great. And how about researchers? How many are strictly researchers? Okay, a lot of researchers. And how many of you have been involved one way or another in ensuring that personalized medicine happens in terms of patient care in the last year? One experience? All right, it's great. It's a lot of us. Well, that helps me a little bit just lay some groundwork here. First of all, I'm not a clinician, I'm not a geneticist, and I'm not a researcher. I'm an entrepreneur, and I'm going to find out exactly how I'm advancing here. Okay. And I think I'm taking a pretty broad definition of personalized medicine. For many of you here, certainly in the School of Pharmacy and Pharmacogenomics, very often personalized medicine is very targeted around right person, right drug. And at DNA Direct, we've been thinking a lot about this whole field of personalized medicine, broadly thinking about everything from inherited risk for disease to disease prevention, targeted therapeutics, as well as really, I guess from the beginning to the end, thinking about how do you find that right person who is appropriate for a test, intervening as appropriately, making sure that the right diagnostic actually gets run, and then most importantly at the end, making sure that the full value of a genetic test is interpreted in a way that's really helpful to patients, families, and other healthcare professionals. And as Howard mentioned to you, I started this company in 2005. We launched our website, and our mission then and has been since our inception to really bring this power of personalized medicine to really reduce health risk, prevent disease, and target therapies. We're based in San Francisco. I have a national network of genetic counselors that are really the backbone of our team. We have over 10 genetic counselors that are full-time with the company, and they are part of a national call center that I'll refer to later. We work with a network of medical and science advisors across the country with different areas of expertise. And our focus really with all the company is to really try to figure out how do you integrate this whole field of personalized medicine and healthcare. It's a daunting challenge for all of us, and we've been, since 2005, really trying to figure out the sweet spot for our clinical services. So very importantly, we're not the lab, we're lab agnostic. We help people, we facilitate access to testing, but primarily we are creating software tools, services, and genetic support. So I wanted to look at I wanted to take some time here and think about where we are today in personalized medicine. And I think it's important to really think about all these different stakeholders. For many of you as clinicians and researchers, you're seeing one part of the puzzle. For those of you who are close to patients, you certainly see some of the patient needs in this area up front and personal. For those of you on the research side, you may be talking with diagnostic companies or labs or pharma and thinking about that translation of science into clinical practice. And I think that each part of these different groups that are represented up here have different needs. And a lot of it that I'm focused around is purely the genetic information, the ability to guide test selection from the payer's perspective, which we haven't really talked about at all. They're looking at which tests should be covered and why. What are the clinical benefits for this? What's the utility of these tests? They're looking at policy enforcement to make sure that the right tests are going to the right lab. To reduce their costs, and they're looking to make sure that downstream clinical management happens as well. So trying to figure out all these different stakeholders has been our company's challenge, and to me is really the way that personalized medicine will get integrated in care. So I'm going to start with early in the food chain with the diagnostic companies, the pharma, and the labs. And right now, the poster child for genomic medicine, I think right now, is this company called Genomic Health. And based in California, they're the ones who are behind the Oncotype DX test. How many of you familiar with this diagnostic? Great, a good number of you. And this has been a challenge for payers. Really, right now, I think Genomic Health, the reason that they are publicly traded and had a successful IPO is because they were able to figure out how to work with payers to really demonstrate a return on investment for the payer community for offering this test. Now, absolutely it has demonstrated patient utility for this. It has, for those of you who don't know, it's going to help identify those patients who have an aggressive breast cancer tumor and those as a result who will end up benefiting from chemotherapy and those who may not. So a clear implication for healthcare, and is obviously I would say at top of mind for any payer who's reimbursing a $3,000 test, which it runs. Myriad Genetics for BRCA, I'm sure all of you are well familiar with, have also launched a very aggressive campaign trying to, again, all these companies are trying to get their diagnostic to market. And they have two challenges. They have the challenge of physician adoption, which is generally slow with any new technology. And they have the problem of how much to push the patient without upsetting the physician, without telling the patient to get this test. They're pushing the patient towards the physicians and encouraging the physicians to find an easy way to help facilitate these kinds of tests and incorporate in their health care. What's interesting, as I look at something like this, you see Myriad saying that they expect 58%, or they actually had 58% revenue growth last year, resulting in their aggressive outreach campaigns to consumers. LabCorp, one of the largest, there are two large general reference labs in this country. LabCorp is certainly one and has made a very grand statement about embracing molecular diagnostics. Most recently, their CEO, Dave King, mentioned that he sees molecular diagnostic and esoteric testing growing 40% a year. So these are all, to me, the trends that we're looking at of how much is coming, how much is in the pipeline. And we look at something like this chart here showing that already there are 200 IVD MIAs actually right now in development. These are complex diagnostic tests like Oncotype DX that require interpretation, require support services, and 75% of those 200 tests are poised to come to market in the next 3 years, bringing new questions for clinicians, patients, and payers. This is just a very small part of the list of personalized medicine drugs that are currently listed with drug information label, approximately 25% of commonly prescribed drugs. It's just a small subset. And to me, this is one of the areas that I've been paying the closest attention to because I wasn't watching this when I didn't foresee this happening, I should say. And Medco, which is a pharmaceutical benefit management company, I don't know if you're familiar with the term PBM, but they're at the heart of the distribution of all pharmaceutical drugs. Medco is the largest PBM in the country, and they have really embraced pharmacogenomic testing. They've started a program already now. I saw a public presentation that they gave mentioning up to 5 million covered lives are being intercepted at the time a prescription is written for either tamoxifen or warfarin at the pharmacist. And the pharmacist is flagging that patient saying, there's a genetic test that can be done to find out if this patient is going to be a poor metabolizer. They ping the physician who ordered it. They ask the physician whether or not they would like to have their patient sent a cheek swab test. And the end result will end up being part of the PBM medical record. Now, to me, this is game-changing. 5 years ago, when I was thinking about this company, there was no such player on my horizon that I thought was going to make such a dramatic impact in healthcare. And just earlier last month, they announced a relationship with Celera around a diagnostic test for statin adherence with K-FIG testing, KIF6 testing, I'm sorry. So that's just a little bit on the diagnostic side and what's pushing today in personalized medicine. I want to take a second and talk about where providers are on some of this. So some providers are really embracing this big time, and they're seeing this as a way of actually drawing patients and physicians to their community hospitals, their medical centers, as part of their growing their business, you know, to position it as part of 21st century medicine. So here's an example of Mass General really toting its program for cancer patients and enhanced cancer diagnostics. Here's an example of Aurora Healthcare and embracing cardiovascular genetic testings, again with KIF6 testing. An example of Intermountain Healthcare in Salt Lake City, creating a genetics institute. And I'll talk later today about our services, about a program that we're launching with El Camino Hospital in California, and I'll show a small video on that at the end. But those are all ways that the providers that we know are obviously embracing some of this. Patients, what we know from our experience providing direct-to-consumer access to genetic testing, we know that the patients that have come to DNA Direct over the last 4 years have primarily been people who have been very motivated due to either a personal or family medical risk or personal medical situation. Early on, people would always say to me, well, so DNA Direct, that must be about a service for the worried well. And I realized that that just wasn't true from the day one when we started the company. The patients that we saw, the customers who came to us, were always people who really had a reason to test, and I started to refer to them as the rightly worried. They actually were looking for a clinical, a diagnostic information. And in fact, over the years, our deleterious mutation rate has pretty much consistently stayed about 40%, which for those of you who are in clinical practice know that the average norm might be 10%. So it really shows that it's been a very targeted population. I think that part of what patients and consumers are looking for is not only direct access to testing, but comprehensive medical information and support services, and I'll go into that in more detail. The next trend that I see right now that I think is top of mind, is certainly in the media, are these genome-wide array scans. So companies like 23andMe, Decode, and Navigenics are offering genome-wide arrays. Has anyone in this room actually purchased one of these tests? Has anyone had one for free? The answer is no.
We purchased some for research purposes, but it wasn't ourselves that got tested.
Yeah. Well, I actually tested with all 3 companies, and maybe later in the reception, if anybody wants to know, I'll hold forth on some of that. But I want to move on here because there's a lot of grounds to cover. But I think the most important trend here is that literally 2 years ago when these companies were starting, this was really controversial. And people like Dr. Francis Collins were just saying, this, somebody's got to put a stop to this. Consumers are going to freak out, they're not going to know what to do with it, and physicians are going to bear the brunt of it. Well, literally last week at NICHPEG, I believe Francis Collins spoke about his own personal situation where showing with his genome-wide array scan that he was at high risk for type 2 diabetes. He's lost 15 pounds, and from his perspective, it was a very important test for personal utility. So I think this definition of when medical information is going to be used for clinical utility is one thing, when it moves into personal utility starts to become another. So now I want to talk a little bit today about where the payers are at on all this, and I think confused and conflicted is part of what needs to be said here. Aetna most recently came out with a very significant statement. This is Joanne Armstrong, their senior medical director, saying that they were going to create a comprehensive program for BRCA testing. They started it with a research study with their own population of employees, and they found out not only were they inappropriately testing up to 20% of their employees, were getting a diagnostic they did not need, they also found out there was a very large percentage of their own population that was not getting testing that could have benefited from it. And so I think what I'm hearing from payers, and we're talking to a lot of them, is that it's not that they're only concerned about reducing the cost of a diagnostic. They're happy to pay for diagnostic if it's going to lead to better treatment and better outcomes. So I think that the coupling of that information is the key here, and we see a trend with healthcare plans in this area. Most recently, Dr. Lou Hoheiser, the medical director for Humana, participated with DNA Direct in a webinar for the American Health Insurance Plan, AHIP. And in it, he publicly talked a lot about the experience working with DNA Direct, where we're providing their utilization management services, and explained why plans feel that they need to really embrace these kinds of tools and services, and why they can't do it all on their own. So the question is, if that's the landscape that we've been working on today, and I haven't talked about all the problems of physician adoption and lack of clinical validity and a lot of other problems that go with all this, because there's more than we can address in just an hour talk. But I want to talk about, if that's the landscape, then where are we going tomorrow in the next 5 years? And the question is, how fast are we going to see this adoption of genomic medicine? And are we here on basically just a slow and steady growth curve, or are we nearing some kind of inflection point? And I always like to think about what are going to be some of the drivers that move it closer to an inflection point. And I think there are really several areas. One is it's going to require a real seamless integration into clinical practice. And by that, it means we've got to have EMRs that actually can embed genetic information. I've talked with some of you about that today earlier. We need to have a robust information and data exchange capability. We need to accelerate research models, and I think there are a lot of innovative ways of doing that, and I'm excited to see and hear about a lot of the research that I think is so important that is being done right here in this institute. And then I think there are also all kinds of wild cards. And you know, I hold up here my iPhone app, which is at work on my desktop here, and I think at what point are we going to have point of care, an iPhone app, that flags the doc at the point of care to say, did you realize you're seeing this breast cancer patient? There's a diagnostic test that'll help them right now, whether it's with family risk or for pharmacogenomic purposes. And by the way, that drug tamoxifen that you're recommending for that patient, you better get a genetic test for that and order your cheek swab here. I mean, it should be point and click, and it should be at point of care. So I think that there will be wild card factors, and I think it'd be fun to talk with some of you in the reception about what you think some of those might be. So back to what some of these game-changing trends will be. We know that with the Obama administration, they're earmarking upwards of $19 billion in economic stimulus, package money to enhance our EMR situation. We know there's, with all payers, an increased interest in payment for disease prevention and wellness incentives. And we know from just what I've been showing you, the growing consumer interest in this. If I dare say if we were in California and I asked how many of you had a genome-wide array, there would probably be a lot more hands raised. But I think there really is a trend, and I may be in one part of the coast seeing more of it than you are here. I think the point of care testing that we talked about, whether it's with a handheld or it's being done in the physician's office, is also going to be a very important game-changing capability. The idea that a physician could right there at the point where they're prescribing a medication find out the genotype of a patient will be increasingly critical. I think accelerating research models is really exciting. 23andMe is obviously created as part of their business model, the ability for patients to start to download information about themselves, about their family history, or about actual medical conditions, and to start to couple it over years when they reach a critical mass with a large number of genomic and phenotypic information. Cornell Institute, with their collaboration in personalized medicine, is really embracing this area with a very extensive study participant list. There are organizations like Patients Like Me that have not yet had a strong genomic basis, but they're gathering information from patients. They started with ALS, being a very comprehensive site where patients with full disclosure, no anonymity, are sharing detailed information about adverse drug reactions, about efficacy of drugs, and very personal stories. And now they're starting to add in information from a genetic perspective. And I think that's going to be very robust. And again, a new model of transparency in clinical research. We know companies like Google and Microsoft with Health Vault are really trying to find a way to create transparent transparent personalized medical records, and providing a place for people to put all data, including genomic information. We know that a company that I wanted to bring to your attention called Private Access is moving in this area of really trying to solve the problem of privacy for personal health records. And interestingly enough, one of the advisors and significant developers of this concept is Sharon Terry, who was your 2007 awardee for patient services. Sharon Terry is the head of the Genetic Alliance, and they represent over 1,000 disease advocacy groups, and they're trying to involve those disease advocacy groups in biobanking and creating, again, epidemiological and phenotypic data that can be mined for researchers down the road with privacy and security in place with this collaboration. So given that there's, we sort of talked about where personalized medicine is today, we talked a little bit about where some of these trends might go. As a businesswoman, as an entrepreneur, I'm always thinking about, do we have the right time, right place for a business? And what is that sweet spot that we need to be in? And actually, who's going to pay us to actually build a company and provide services? So I'm going to take a different turn here and actually now just talk to you about what I'm doing today at DNA Direct. But the question that always comes up is, so what's the business model? So I think the important part is we've tried to think about these different stakeholders, and at the center of this slide talks about really two clear areas that we are offering as our service offering, either through a software licensing, consulting services, transaction-based, fee-based services. With utilization management, I mentioned talking that we're working with large healthcare plans. We're also talking with large employer groups, the self-insured payers, to help identify who's appropriate for testing and who can benefit from testing. On the clinical decision support side, we're working with healthcare plans and as well as provider organizations to basically web enable genetic expertise. We didn't really talk about here today, but I'm sure many of you are aware that there are only around 2,000 genetic counselors around the country. Depending on how you cut it, there are probably only another 2,000 MD geneticists that are in clinical practice today or less. So it's a small number of people with genetic expertise and an even smaller subset of some of the skill that's here in pharmacogenomics. So how is that going to be translated throughout healthcare? I believe is going to have to be with web-enabled tools, with information, with services, with applications that help providers and patients think through some of these decision tree processes. So we've developed on one side of our core architecture our software and software solutions, and on the other side we couple it with people, a national call center of genetic counselors that, depending on the service that we are offering, are available 5 days a week, sometimes 10-hour shifts overall, answering on the telephone from east to west coast, and being able to be at the end of the phone for a physician, a payer, or a patient who has a genetic question. So when I look at the business opportunity for this, I look at genetic testing. That market is, this year, a $3 billion market. We know from these companies that I was just pointing to that it's expected to grow at 45% a year. We know from members, from patients, that Consumer Reports and others have stated that 8 out of 10 patients are interested in genetic testing. And we also see on the flip side that 9 out of 10 physicians expect to be using genetic testing in their practice. When, is going to require these different tools. We know that there's a rising cost to the payer when you think that if 20% of genetic tests are inappropriately ordered, that's a $600 million problem today that payers feel. So again, looking at our primary customers from the payer side, number one on the left is we're really talking about an example here of Oncotype DX, pointing to patients who do not need to be on a chemotherapy protocol. Chemotherapy average cost $30,000 a year for a patient. And if right now when somebody is given that Oncotype test, they're scored at a particular point where they are in that continuum, and yet still 15% of those patients are getting chemotherapy that may not have any benefit from it. So from the plan's perspective, they're looking at how do you reduce that margin? It's not going to be 0, but could it be 5? Could it be 10%? Paying for unnecessary tests, as I mentioned, is it only a part of the equation. Obviously, looking for people who can benefit from testing is another part of the equation. Our secondary customer are really these large medical centers or hospital centers. And what we've seen are really 2 reasons that they've wanted to outreach into this whole field of genomic medicine. One is they know that a medical center that is really practicing 21st century medicine is going to attract, as they put it, high-value patients. And it's, again, if they lose an oncology patient or a cardiology patient because they're going to go, 10 miles away or 100 miles away to the major academic medical center because that's where they can get state-of-the-art diagnostics, that patient's not necessarily going to come back to them, to their community hospital. So that's part of the driver. The other part is they need to be making sure that their physicians that, you know, are the cornerstone of their practice are actually satisfied and feeling that they are practicing in an environment that is supportive to innovation and patient satisfaction. So I think that's another underlying reason. And needless to say that for all of these different constituents, ensuring that patients are getting better quality care is fundamental to all of it and across the continuum. So what have we built and what are our solutions? Number one, I'm going to take it from the payer's perspective. We've built at the cornerstone of this genetic expertise that we leverage across this continuum. We provide in the clinical to support pre- and post-test decision, both by phone and by web-enabled tools. And on the utilization management side, clinical policy that we work with based on a particular plan's specific clinical policy. Utilization management we've talked a little bit about, but I think in terms of key features, we basically have web-enabled those clinical criteria. So for example, who should benefit from BRCA testing? Do they have a family history? Are they of Ashkenazi Jewish descent? Age of onset, and things like that. We've automated that already for over 70 of the most common genetic testing categories, and we're growing that number exponentially. We've created a provider portal so that a physician can go in and pre-authorize a patient at the point of care to make sure that that molecular diagnostic test that they're ordering is going to be covered for that patient. This is just a mock-up of one of them, but we're creating, with these portals, we're creating customized CME courses, webinars, providing information real time about new advances that are going on in their field that are relevant to their practice. I'm going to just take you quickly through the pre-auth system, just very basically. This is up and running right now with Humana. This is just a generic one. This is not patient data, but just showing you that they log in, they put in a CPT code, it verifies member and provider eligibility, captures name and test. There's a questionnaire that's customized to the plan's policy. Clinical summaries are embedded. There's a question on the little right-hand side why we ask, so that at every step along the way, physicians are being educated, or the physician's office is being educated about the rationale behind these guidelines. And I should take a minute to say that I think the physician education is absolutely key to one of the drivers behind this from the payer perspective. They want to make sure that physicians are continuing their education and knowledge in this area because, one, we know to begin with many of these physicians are not trained in medical school around it, and two, the field is growing too fast for them to keep up all on their own. So at the end result, as they go through the pre-auth system, they can determine whether or not it meets criteria, and it'll actually help direct them to the preferred lab by the payer if appropriate. And at any time they can log in and either email our genetic experts or call them directly. So right now with our guidance program for Humana, we're in really phase one of it. We've done the pre-auth program that I've started to show. In 2010, we're hoping to roll out genetic counseling for plan members on a as-needed basis, referring members to participating labs, referring into clinical programs for disease management as appropriate, and to provide more comprehensive provider and member education. So now just a little bit of how we're working with providers. So again, thinking about these clinical decision support tools. Now, when you think about that community hospital and the ways that we can help a community hospital, we've provided risk assessments and family medical history tools that physicians can utilize or patients can utilize online, personalized reports based on genetic test results, and again, access to our phone experts. So now just looking at a customized patient portal for these medical centers. This is an example up here of something that we're calling the prenatal primer. And basically what we've done is, I would say, web-enabled the decision-making process that goes on in a prenatal counseling session. For a pregnant couple that comes in and goes through prenatal screening, This is a way of web enabling it where they can go through it at the privacy of their own home. They can go through this decision module, ask very personalized, very personal questions, and it's tailored based on results, and basically helps them guide them through. Are they interested in amnio or not? Why are they interested? What kinds of decisions do they want to make? And then share that information with their doctor. And it will actually download an informed consent and get it embedded in the physician's medical record with the practices that are participating. This is an example of the same kind of decision support logic, a web-enabled tool, this one for breast and ovarian cancer. And again, it helps an individual go through that process that prior to this kind of tool would only have been done in either a face-to-face genetic counseling session or in some cases by phone, as if through DNA Direct and by web, but we've web-enabled the whole thing so that it can augment that kind of counseling session as well. But I just got a few screenshots, so starting out, again, customizing it based on a little bit of their personal profile, collecting information and making, and basically triaging somebody through the actual tool. In this situation, they gave information, they went through the decision support module, and it pointed to multi-site testing, and it goes through the pros and cons of it. They can look at a patient video for any different piece of it and look at, frequently asked questions or explore different test options. This is an example of a different tool of what we call personalized reports, and I'm sorry, it's a very small print here, but basically this one is for a 2D6 test result for tamoxifen. And again, these reports are designed for the patient to go through privacy of their own home, to think about it, raise questions, bring this information to their physician. There's a physician letter that's a 2-pager that basically talks about what the results of the test are and clinical guidelines for the physician. But the information that results on this for the patient is something that they can share with family. They can look at other drugs, for example, that are metabolized by the 2D6 pathway and make other long-term healthcare choices. And then I wanted to really sort of close with just an example from the hospital that I mentioned that we're working with in California and Palo Alto, called the El Camino Hospital and their Genomic Medicine Institute. And this was a big idea that the hospital had to actually try to figure out how could we take our community hospital and compete with the likes of Stanford University about 10 miles away. Well, thank you. I think I'll close on that note, and I'm happy to take any questions.
Questions? Right.
So I understand and appreciate your emphasis on point-of-care testing. Do you see any conflict with that and sort of this historical emphasis on patients being able to make choices about whether or not to have testing? I mean, if it's right there, doesn't that sort of...
Right. I think, the traditional model of genetic counseling just doesn't hold up with pharmacogenomics. And I guess I'll just say the reason for that is that there's the whole baggage that has to go through, which I think is a lot of baggage in some cases, where in-depth pros and cons of should you test or shouldn't you test is really, I think, in a way, overstated when it comes to whether or not a drug is going to work for you. I think it's pretty black and white of whether or not somebody wants to make that kind of decision. Now, I'm sure there are cases where there's a lot more involved in all that. In terms of for DNA Direct, the more complicated the decision-making process, in a way, the more we can add value, the more that we can add support services around it. But I look at point of care and saying, there's some things that, like HER2 testing, where a woman really doesn't even know what happened. And unfortunately, only 75%, we just saw in a study, of women who probably should be getting HER2 actually get it, even though it's standard of care. So I think there's a role for the patient to really be informed and knowledgeable, to be their own advocate, but I don't think it's necessarily about the old paradigm of informed consent.
Christy?
In your business model, do you expect that you're going to make the majority of your income from patients coming to use your services, or payers coming to use your services, or physicians coming to use your services?
Sure, it's an important question, and one that, as you can imagine, we've had to think through a lot of who pays for these services. And I think the bottom line is patients really don't want to pay a lot for information services. They expect information and advocacy and informed consent all to be coming through the healthcare system miraculously, and it just doesn't happen. So we've swum upstream and said, who has the most to gain for informing your population and helping them with informed decision-making, and it's the payers. It's the large self-insured employers, it's the big healthcare plans. These are, I would say, our primary market. In addition, we're looking at major medical centers and trying to help them embrace these new technologies. And I think there, because my focus, and I didn't talk as much about it today as maybe I should have, but I hope it's somewhat transparent from my intro, is I've been at this for 30 years thinking about how patients can make better healthcare choices. Who pays for that has always been a question. And, but that's still my focus is always on the patient-related service. Yes?
Just sort of following on to the question before about whether informed consent really ought to just get sort of tossed out because these tests need to be done and sort of, would it change your opinion if, say, one of the SIPs was found to be associated with an increased risk for Parkinson's disease or Alzheimer's disease or something where you think that you're just doing a test to measure somebody's response to tamoxifen, but in fact, you actually could reveal something about them they may or may not want to know.
Yeah.
Somewhat in the same way that ApoE4 has kind of done that.
Exactly. No, it's a really good example.
It's a valid clinical use for cholesterol, but also provides other information.
Yeah, I think I was probably too quick just to respond to the question of saying the old model doesn't hold up. I think there has to be some give and take in this model, and I think your example is absolutely correct, that where a diagnostic is going to have an impact on potentially other family members, unintended consequences for that actual patient needs to be thought through. And I'm a strong believer of informed consent, not the informed consent to cover your bases kind of informed consent, but the kind that is really helping make informed choices.
Stephen?
How do you envision physician medical education being funded?
Good question. Again, I look to the payer. Right now, this pre-authorization program that we're offering right now with Humana and certainly with others that we're in discussion with, physician education is absolutely key. Education to the provider's office is key. So at the time that a diagnostic is being ordered, these tools that we're creating are allowing the doc to go on and see why we ask, why is this relevant? Why do we care about ethnicity on this test? Oh, that's why. And hopefully it'll become part of their understanding about these guidelines. I think that another thing that I mentioned was the fact that we were involved in continuing medical education courses. Again, that's funded through the healthcare plan or the provider organization.
What genetic markers do you integrate testing for patients right now?
What genetic markers?
Yeah.
We have not grown our offering tremendously from when we started. We started with the most commonly well-validated medical genetic tests. So cystic fibrosis, factor V Leiden, underlying genetic causes for infertility, BRCA. We added in pharmacogenomics, tamoxifen, warfarin, drug metabolism panels. But our support services that we're offering to these providers and plans are much more all-encompassing. So a lot of tumor assays like Oncotype and other cancer diagnostics, we're supporting the decision support tools or the personalized reports, even though we're not handling the actual lab diagnostic. Yes?
So I know that you all have a group of counselors across the country that you can refer patients to. In fact, I think I'm signed up to be one of them.
Oh, good.
But my question is, when do patients get to us? Like, when would they, is it from a recommendation from one of your counselors where they've talked with the patient and they said, this person's just not getting it, you would benefit from a more face-to-face? So sort of when does that interaction take place? Does it take place, is it an offer for everybody, or is it just like a triage?
Yeah, it's a triage, and I'm glad you brought it up. We have, as employees of DNA Direct, about 10 genetic counselors involved in the company, and they are the first ones up on the phone with all of our different customers. They do phone support, and they help web enable these tools and provide genetic education and content and all of that. We have a network of, I think, somewhere around 75 different genetic counselors who have offered to be part of our extensive network for referral purposes. So at the point that we are, at any point our genetic counselors are involved in either pre or post-test counseling, and we find a patient where for one reason or another that counselor on the phone doesn't feel that that individual is really going to benefit fully from just doing something over the web, or they express an interest in doing something face-to-face with a counselor, we look through that network to see, is there somebody that we can refer out to? And of course, we also just look out to the NSGC list if it's something that is more appropriate geographically. Trish Brown, who heads up our clinical affairs, would probably know how often we do that. I wouldn't say it's a lot that we feel a need to do a referral out or that we get a request for. And again, that's partly a self-serving, a self-selection thing. But I know there have been instances where we felt that we really couldn't help that patient for whatever reason. And we really felt that face-to-face was going to be important. So.
Well, there's time for reception where you can ask additional questions. I was up half the night baking some goods for you to enjoy. But we just finish off with congratulating Ryan once again for this award.
Thank you again. Thank you.